about one bout of hepatitis per year in India. We are talking of acute viral hepatitis. So how we are going to cover the topic? First, we will look at what exactly is acute viral hepatitis. Then we will look into the etiological factors. We will look for two important causes of the acute viral hepatitis. We are not covering here hepatitis B and C because they will be covered more in chronic viral hepatitis subgroup. And in the end, we will look at how to prevent this acute viral hepatitis subgroup. So how do we define acute viral hepatitis? This is an inflammatory disease of the liver which is usually associated with complete histological and clinical resolution within a period of 4 to 6 weeks. So it is something like you have a illness which automatically is going to clear up over some time. So what is meant by hepatitis? As you all know that itis, wherever it is written, it essentially means inflammation. So hepatitis essentially means inflammation of the liver. And why we are calling it acute? Because symptoms usually last for less than 6 months. And what is another terminology which we should understand is what is called as acute liver failure or acute hepatic failure, which means appearance of encephalopathy and of coagulopathy within 4 weeks of onset of jaundice. We call it chronic once inflammation is there for more than 6 months. And what is cirrhosis? Cirrhosis is basically replacement of liver tissue with the fibrosis. Here you will find regenerating nodules along with fibrosis. Why it is important? Because it usually leads to loss of the liver function. So there are, when we call hepatitis, essentially we are meaning hepatotropic viruses, but other viruses can also infect or cause illness in the liver. Hepatotropic viruses are those which are predominantly associated with liver diseases, named A to E, although G and H are also known there, but main concern is A, B, C, D, and E. Other, as a component of a multi-system disease, we can have it as a part of herpes simplex, CMV, EBV, and almost all viruses can secondarily infect liver. Most of the cases of acute viral hepatitis in India are thought to be related to hepatitis B virus, but since it is covered with chronic viral hepatitis, so we will talk when we are dealing with chronic viral hepatitis. Hepatitis D virus cannot infect liver alone. For this, you require hepatitis B virus infection, and if it is superimposed with hepatitis D virus, hepatitis D basically is an incomplete virus, so it cannot infect liver primarily. So for hepatitis D virus to infect liver, you should be pre-infected with hepatitis B. As far as hepatitis C is concerned, it rarely causes the acute picture, but whenever it causes acute hepatitis, usually it leads to chronic hepatitis. Most of the acute viral hepatitis are self-limiting, and the most direct complication of acute viral hepatitis is basically a fulminant liver failure or acute liver failure, and it ranges from 0.01 to 1%. So what are hepatotropic viruses? These are viruses that cause similar type of an acute illness. Usually acute phase causes low or mild symptoms, and morbidity, it is a rare cause of acute liver failure, and chronic state and complications which are associated with hepatitis B, C, and D. So if you look at viral hepatitis, the viral hepatitis can be infectious, which is what is called as fecal-enteral transmission, and it is associated with hepatitis A and E. The other one, which is called as a serum type, which is usually hepatitis B and D. And then there are subgroup which is called as a non-A, non-B, which is usually hepatitis C. The below part of the picture is usually transmitted parenterally. Both all the hepatitis, whether it's hepatitis B, C, or D, they are usually parenterally transmitted. Hepatitis A and E are fecal-enteral transmission is there. So it is basically caused by food or the drink which we consume. The more problem with the hepatotropic viruses is that they can have both cytopathic as well as immune mediated. Cytopathic means where virus directly injures the cell and causes damage to the cell. But most of the problem with viral hepatitis or hepatotropic group of viruses is that they cause uh, immune mediated injury, which involves uh, almost all of the liver, causing severe damage. If it is immune mediated, most of the time it leads to necrosis, and an acute mixed inflammatory infiltrate you will find if you take a liver biopsy, predominantly centered in and around the portal areas. There might or may not be there is a bile duct proliferation, which basically it means that the liver cells as well as the biliary epithelium is getting damaged. It also causes what is called as a Kupffer cell. Kupffer cells are an important immunogenic cells in the liver, and they are the one which present the antigen mostly to the liver, and this leads to generation of what is called as immune mediated injury. So how do we approach this picture? You can always get in from the Harrisons, from where we have taken this picture. The most sensitive symptom for hepatitis is anorexia. Anorexia, nausea, and vomiting are usually the most common feature of acute hepatitis. Remember that jaundice may or not be there. So high colored urine may or may not be there. So anorexia is the most important symptom for acute viral hepatitis. And suppose someone who is a smoker develops suddenly there is a distaste for smoking. That's usually the most noticeable symptom for acute viral hepatitis. Once the patient presents with this, we normally tend to get the blood tests, and liver function tests, both ALT and AST, are elevated. But once we are restricting ourselves to viral hepatitis, usually ALT is more than 10 times uh, the upper limit of the normal. So, for example, in our laboratory, it is 40. So, we think of acute viral hepatitis if it is more than 400 or 500 figure. We have to meticulously exclude other causes like drugs, like alcohol, like ischemia, underlying diseases, and more importantly is the biliary obstruction. So then we go for other tests which will establish the diagnosis of acute viral hepatitis. Most important being the serological markers. Like for hepatitis A, we do IgM antibody, anti-HAV. For HEV, again, we do the same. For hepatitis B and C, we do surface antigen along with IgM anti-hepatitis B core antigen. And for SCV, we do anti-SCV. And if all tests are negative, say for example, then we have to look for systemic causes, something like CMV, Epstein-Barr viruses, or herpes viruses, or even if it is not there, then we look for factors like autoimmunity and something like ANA, asthma, and anti-LKM antibodies are to be checked for, and finally the metabolic causes like Wilson's disease. We do see a lot of cases for Wilson's disease presenting as acute viral hepatitis leading to acute liver failure. Now let's come to individual group of viruses. First is the hepatitis A virus. Hepatitis A virus is enterovirus of picornavirus viridae family. It's spherical, it is non-enveloped, and it is endemic in India as it is in most of the developing countries. So if you want to look for hepatitis A virus, everyone should know that most of the people below the age of 10 years do acquire hepatitis A virus. And in these subgroup, basically it presents with diarrhea rather than a true hepatitis like a picture. If you look at sporadic cases of acute hepatitis, more than half to two-thirds of them are associated with hepatitis A virus, especially in children. It is highly contagious, and as I told you that both A and E are fecal-orally transmitted. The immune incubation period is close to 3 weeks. It means that if I have contracted infection today, the symptoms or florid disease will be there somewhere around 3 weeks down the line. What we have to understand that the fecal excretion of the virus starts from the incubation period, and it reaches its peak just before the onset of symptoms and resolves by 2 weeks after the onset of jaundice. For infants and children, it is usually longer duration of excretion is there. So if you look at people who will be infected and will have symptoms of jaundice, if person is infected late in the course of hepatitis A virus disease, which means if the person is more than 15 years or 14 years of age, jaundice will be there in almost all the cases. The complication with the hepatitis A virus, as I told you, that the most dreaded complication is acute liver failure or fulminant hepatic liver failure. There is a relapsing cholestatic type of an hepatitis, which essentially means that if a person is infected with hepatitis A, gets cured for hepatitis A, and he will have recurrent symptoms of itching occurring over a period of month or 3 months or even up to 6 months. Usually there is no chronic sequelae associated with hepatitis A virus. This is the typical graph showing how the virus is being excreted fecally. When the symptoms start, when the enzymes or ALT, AST tend to go up. So fecal excretion of hepatitis A starts even before the onset of symptoms. And if you look at the ALT typically goes very high during the 3rd to 4th week of the illness, and thereafter gradually it comes down. The antibodies against hepatitis A appear about 2 to about a couple of months down the line, and gradually they disappear. So how it is transmitted? The most important is a close personal contact, the contaminated food or water, and very rarely it has been reported to be transmitted through blood. Remember that whenever we are talking of hepatitis A and E, we are basically talking of fecal-oral transmission, which essentially means contaminated food and water is the most important source of infection. So if you look at the global percentage, the global scenarios for hepatitis A virus transmission, if it's a very high endemic region, as we are one of them, person to person contact is very common, and outbreaks usually occur related to food and drinks. In very low endemic areas, as occurs in most of the European countries, the travelers are usually infected with hepatitis A virus, and that leads to sporadic infections of hepatitis A virus. So this is a word over the prevalence of hepatitis A virus. If you look at the red color, which shows high prevalence, the Indians belong to this high subgroup, as is whole of the Asia, Latin America, and Africa. So as I told you that infection is diagnosed only by IgM anti-HAV, which is the antibody against the hepatitis A virus. And if we want to look for past infection, we do what is called as IgG, immunoglobulin G. Remember that all the acute infections are associated with uh, finding IgM antibodies against the given subtype, and IgG usually shows the recovered or past infection. So if you want to get rid of hepatitis A, the most important thing is that uh, vaccination should be given, which people require vaccination. You have to take full care of that. Highest attack rate has been reported between 5 to 14 years of age. So these are the subgroup of people who might benefit with vaccination. But as I told you that in our country, most of the people by the age of 5 years do acquire hepatitis A vaccine. So in infants and in the early childhood, usually uh, vaccination against hepatitis A is recommended. But for countries where endemicity is very, very high, we really don't know what is the outcome of this vaccination strategy. The person who are at increased risk of infection, the travelers are the most important, homosexual men and injection drug abusers. So if someone is planning to belongs to a low endemic area and plans to go to a high endemic area, then we can give what is called as an immune globulins. These are pre-selected antibodies against the hepatitis B, which are going to be given parenterally. So post-exposure, how do we go for prevention? Within 14 days, routine is household and other intimate contacts can be given this immune globulin, and in selected situation, as we prefer to do, is an institution. Say, for example, there are people uh, who are mentally challenged, and they are living in a one closed corridor. And if someone gets infected with hepatitis A, then it is prudent to give immunoglobulins to other inmates, so to avoid what is called as a sporadic handling, or maybe which may go up to epidemic proposition. Now coming to hepatitis E subgroup of virus, again the here average incubation period is about 40 days, range being 15 to 60. Case fatality rate is not very high, it's about close to 1%. What is worrisome is that if a pregnant female gets infected with hepatitis E, then chances of it causing severe illness is very high. It's close to quarter, 15 to 25%. Illness severity usually increases with age. Chronic sequelae is usually not identified, but except in cases who are alcoholic and those who are having diabetes mellitus, the virus is known to survive in the body for more than 6 months. This is the same typical picture of hepatitis E virus infection. Remember that here we are talking everything in terms of weeks. Virus starts shedding much before the symptoms do appear, and symptoms usually are associated with high levels of uh, enzymes. Usually, ALT, AST goes very high, and just before the onset of symptoms, we can find the IgM anti-HEV. So if we look at epidemiological features, most of the outbreaks usually are fecal-oral contamination. Many of the things have been reported as an epidemics world over, and India being one of the pioneers in reporting the epidemics of hepatitis E virus, we have very low prevalence of anti-HEV in normal people, and minimal person-to-person transmission is reported. Look at this prevalence ratio; it's almost similar for hepatitis E also, as was for hepatitis A. So, how do we control and prevent hepatitis E virus? Is most important is avoid drinking water which is which comes from an unknown source. So water, if someone wants to have, it should be very well filtered, or it should be boiled and then cooled down, and then we should consume it to avoid hepatitis E. Similarly, we should very meticulously wash the fruits and vegetables which are supposed to be taken raw. Any food which is going to be cooked usually kills the hepatitis E virus, but if it is suppose it is to be taken as raw, for example salad, we should be very meticulous in cleaning it. As for hepatitis, in contrast to hepatitis A, hepatitis E usually is not prevented by immunoglobulins, and vaccine, we really don't know whether it is working or not. Multiple trials are underway for hepatitis E virus vaccine, but none has shown promise so far. If you look at similarities between hepatitis A and E, both have acute onset with mild illness. Both are transmitted fecal-orally. The major difference is that HAV occurs usually in children, while HEV usually occurs in young adults. It is said that if hepatitis A occurs in adulthood, it causes severe illness, but hepatitis E, if it occurs in adult subgroup, usually it causes mild disease. The only dreaded complication for hepatitis A E virus is basically acute liver failure or fulminant hepatitis, usually in pregnant females, and secondary attack rate, which essentially means person-to-person transmission for hepatitis E is very low as compared to hepatitis A, which is very high. So you have to understand that all acute viral hepatitis recovery is very high. So more than 90% of the people who are getting hepatitis A or E will recover in due course of time of 4 to 6 weeks. Relapse does occur. It occurs in up to 20% of the cases, and rare need for hospitalization of these patients. Only when it occurs that there is a patient who has a severe disease, what is called as acute liver failure, it requires hospitalization. Rest everything can be managed as in-home basis. So we have been talking about this acute liver failure. It is the dreaded complication, as we all know. The earliest definition came from Craig Davidson. It means that encephalopathy with or without coagulopathy. Remember that when we are talking of acute liver failure, we are basically interested in only two factors. One is sensorium of the patient, and the other one is the coagulation parameters. If patient is having altered sensorium within 6 months of the onset of the acute onset of the jaundice, then it was used to be called as acute liver failure as originally defined. But the basic research from India has changed the definition of acute liver failure, and now we know that it is if preserved previously liver functions are known to be normal, liver was sonologically, which means that on ultrasound basis liver was normal, and sudden acute liver injury leading to impaired liver function and encephalopathy within 8 weeks, which means 2 months, then it is usually called as an acute liver failure. And now we have modified it further that any patient who develops encephalopathy with or without coagulopathy within 4 weeks of the onset of jaundice. Here we are not talking of the illness, where we are talking interval between jaundice and encephalopathy. Similarly, jaundice and coagulopathy. So if the duration is less than 4 weeks, then now we assume it to be acute liver failure. And here we need to be more vigilant. Remember that acute liver failure cannot be defined without the presence of encephalopathy. If patient is absolutely conscious, normal, with a normal coagulation parameters, is his liver is functioning not normally, but it is not causing a severe injury leading to uh, acute liver failure. Remember that acute liver failure even today has a very high mortality. So I told you that almost all the diseases which infect liver can lead to acute liver failure. So how does it manifest? Remember, acute liver failure is a disease which does not involve liver alone. Its symptoms can be very varied. Say, for example, it involves uh, brain in the form of brain edema. It leads to hepatic encephalopathy and raised intracranial pressure. Similarly, it can lead to ARDS, acute respiratory distress syndrome, leading to ventilatory support for the patient and other things. What major problem with the liver failure is that it leads to what is called as immune paralysis, whereby neutrophil stop functioning normally, and then it leads to systemic inflammatory response syndrome. It also leads to very rapid catabolism of the muscle tissue in the body. Uh, so have very high catabolic rate. It also can involve the kidneys, leading to renal failure and adrenal insufficiency. Rarely it causes portal hypertension and pancreatitis. Cardiovascular collapse or endothelial dysfunction is also known. And other thing is that it might systemic inflammation also involves the gut, whereby it leads to ileus. Now, if someone has developed acute liver failure, how do we treat it? So, for acute liver failure, management is basically the management of complications. The most important and dread complication is the cerebral edema. Here, how do you decrease cerebral edema? You have to make the patient semi-reclining, which means that head and trunk should be elevated by about 30 to 40 degrees. Avoid unnecessary motion of the head. The room should be cool and calm. Avoid exposure to the light. Then most important thing is that we should look at the ABG. I told you that it might lead to acute ARDS. So we have to be very careful and meticulously monitoring the oxygen and carbon dioxide concentration. To decrease the cerebral edema, mannitol has been reported to show wonderful results. Even a single dose of mannitol decreases cerebral edema to more than 30%, and it almost immediately leads to increase in consciousness level of the patient. Suppose it does not work, then ultimately it might lead to we might have to use what is called as a barbiturate coma, which essentially means that we are giving high doses of barbiturates to decrease the cerebral edema. The other complication is usually infection. I told you that acute liver failure is usually associated with immune paralysis. So sepsis is very high on the cards. Most of the time it is the gram-negative bacteria. And we in our setup invariably use parenteral broad spectrum antibiotics, usually with the cephalosporins, with fluoroquinolones, give a very good result in patients with acute liver failure. There have been reports of prophylactic use of antifungals also, but as of today, we do not advocate use of antifungals in the early or in the beginning of the disease. Coagulopathy associated with ALF is non-preventable because it is because of the liver function. So some factors which are produced by liver are not being produced. The in coagulation cascade, which are very important, and if they are not produced, coagulopathy will be there. Remember that fresh frozen plasma, which is being used for coagulopathy associated complications, should never be used prophylactically. Unless there is a bleeding, do not use FFP or fresh frozen plasma. Why do not use plasma prophylactically? Because it increases the cerebral edema ultimately. And if cerebral edema is increased, it might lead to coning and ultimately the death, compression of the medulla. Medulla is the one center which controls almost all the major parameters like respiration and cardiac factors. and it might lead to almost sudden death of the patient. Treatment, as far as for acute liver failure is concerned, it is liver transplant, which is required once we know that the chances of survival are less than 20%. The major contraindications being the irreversible brain damage, sepsis, uncontrolled sepsis, presence of HIV or concurrent malignant disease. Suppose liver is not available, then auxiliary liver transplant is another option, which is again only in experimental cases. This slide should apprise you that therapies which should not be used for acute liver failure, which means they are of no use. They only increase the burden of finances to the family without any proven benefit. Remember that the mainstream of the therapy for chronic or chronic liver disease or cirrhosis is lactulose. Lactulose is ineffective in acute liver failure. Similarly, a very fancy drug, LOLA, L-ornithine L-aspartate, has not shown to be of any use in acute liver failure. So these two drugs usually do not lead to any improvement in the liver diseases as far as acute part is concerned. For chronic, we will discuss during the chronic one. Similarly, branch chain amino acid have no proven role. I told you that FFP should never be used unless there is a bleeding. Prophylactic use of FFP might be fatal. The enteral or gut specific antibiotics have been used, but they do not work. See, enteral decontamination is the main therapy for chronic liver diseases, but it does not work in acute liver failure because here the liver is basically studded by immune paresis, and that's why these therapies usually do not work. Prophylactic anticonvulsant. Say someone says that there is cerebral coma or there is cerebral edema leading to coma. Why not give anticonvulsants? But as of today, they have not been shown to be of any benefit. Prophylactic hyperventilation for intracranial hypertension does not work. We do use hyperventilation in grade 4 coma when there is the patient is having what is called as a seizures. So that's all for today. I will take up the questions if there are any. You can write down the questions and then I can go ahead and answer them all. Thank you.